and we are delighted this afternoon to have with us our new Director of Health and Human Services, Tony Keck. You all know that he's coming. We talked about it this morning, making sure that you behaved properly. I told him we would not be immoral if we could help it. And I also told him that obviously he didn't say that, and we know that that we need to dispense with that with a little humor and then move on to the issues that we all have in common, and that is working on the future of our state Medicaid program, our current and our future. Tony is going to talk to us about the state Medicaid program and the budgets and all those issues, and also give you all an opportunity to ask him questions and talk with him. And we're very grateful he'll do that. He served under Governor Bobby Jindal in Louisiana as the Deputy Secretary for the Department of Health and Hospitals there before he came to South Carolina. And he has also has a good bit of business experience running businesses, not just state agencies, but hospitals as well. And in our conversations, I have been really impressed by the fact that Tony understands Medicaid. He understands the purpose of this program, the spirit of the program, but also the realities and the constraints within which we are all operating right now. So I personally am very confident we have a director we can work with and who wants to work with us. I'll tell you, the very first thing he said to Alan and me when we met with him was that he was very impressed with our Safe Surgery project. And that was music to our ears, that quality of care in this state is important to our Medicaid director. So without any further ado, Tony, welcome to South Carolina and to our meeting.
Well, thank you very much. I appreciate it, and Thornton is right. You know, part of my decision to come here was not to come and see the opportunity to cut rates. You know, any fool can do that, but the opportunity was to actually make something happen. And so I spent a lot of time with my family evaluating, you know, can we make something happen? Can I be part of that team that does it? And really the two deciding factors were, one, the governor and my interaction with her and her vision and her excitement and her enthusiasm and her management style, and two was, you know, what's going on in South Carolina that's exciting, that is really on the cutting edge. Because it's one thing to come in and, like we were in Louisiana, with 0% managed care and sort of being at this end of the curve, but to look at the state and see that there was high managed care penetration, that the hospital association, instead of simply always just worrying about rates and other things, they were worried about improving quality and had demonstrated that they were actually, as a group, investing in all that. It made a big difference. It made it clear to me that this is a place where really exciting things can happen. So one of the things that I think that we really need to do in the department is make sure that we're just not communicating with you when we want to change something, or when we've got a problem that we need to fix. We need to create strong relationships where we're regularly touching base with each other about common goals. And we're going to have some goals that aren't common, but we're going to have a lot more that are. And so my commitment for this agency, while I'm here and hopefully after I leave, is to make sure that it's not only responsive to the industry, but it's actually proactive about going out and understanding, you know, where are we going and creating a common vision. And so that's the governor's mind and my mind, that folks don't have health insurance is because health insurance is too expensive for what it delivers. And that's the reason that health insurance is too expensive for what it delivers is that we're not getting the health outcomes we want, or it just costs too much to produce. This is a very simple equation. People don't buy health insurance because they don't find value in it. When people find value in it, they buy health insurance, whether it's an individual, whether it's an employer, and so on. And so that comes down to two main principles. Is one, we've got to produce better outcomes, and that's where I've seen y'all do a really great job. I looked at the United Healthcare Foundation rankings for South Carolina this year and last year, and I think that one of the reasons that South Carolina jumped up 5 spots had a lot to do with one of the single factors, is that you guys decreased hospital readmissions by a considerable amount. And I know that was a team effort that probably included other folks in the system, but I think it's a big deal. So we've got to deliver better outcomes, and we've got to be able to measure them, and we've got to be able to communicate them to the purchasers of healthcare. Alongside of that is we got to drive cost out of the system in healthcare. And so as leaders, that's our job to figure out how do we narrow that gap between value and price, and how do we work together to do it. So the governor has tasked me to work with you, and I'm going to take questions after this little bit here because I want to hear from you. She's tasked me to put together a plan that is a South Carolina plan, not just simply a response to national health care, not to stamp our feet and squeeze our fists and not want to do Obamacare. That's not what this is about. She's got a clear vision that to continue South Carolina's rise as a growing industrial state, as a growing state in terms of high technology, in terms of jobs, and to deal with the fact that it's an in-migration state where a lot of older folks are coming into the state now and our demographics are changing. To stay competitive and to deal with the changing demographics of the state, she recognizes that we have to fix healthcare locally, and we've got to do it in a way that works for South Carolina. And this is where I'd like to ask to work with you going forward is payment reform. I think we've talked about this for a long time. We all know that the way that we get paid drives our behaviors, and that's okay. I mean, that's the whole point. The whole point is that we perform a service, we produce a product because we know we're going to get paid for it. The question is what is that product? Over the years, it's been defined as, well, that product is healthcare services. Well, I think a lot of us are now understanding, well, no, really what we shouldn't be producing is healthcare services. What we should be producing is health. And those are two very different things. And so we've got to get to a model of payment reform. And that is a broad terminology for a lot of complicated negotiations and efforts to get to there. But payment reform, which focuses on paying for health instead of healthcare services, has got to be one of those strategies. The other strategy to help you all do that is in order to drive costs out of the system, is to make it easier for hospitals and doctors and other providers to actually do the business of healthcare, to lower your cost of inputs, because we know that your prices are driven by the prices that you have to pay, the prices that you have to pay to doctors you employ or nurses you employ, the technology you purchase, the capital investments you need to make. And so I think there's clearly many strategies that the state can engage in to either foster, encourage, can pass laws, can relieve regulation, to actually make it less expensive for you to operate in the state. And so this is all about the margin. And so if we're going to drive cost out of the system, but then we can, in terms of what the state pays, if you can also drive cost out of your system and we can preserve those margins, that's what this is really about. But there's a lot of room, I think, in the current system to drive cost out of the system, improve outcomes, get health care to more people. And we're going to have to work on it together to do it. I have no illusions, that I walk in after 3 weeks, that I have anywhere near the relationships that you all have, that I have anywhere near the knowledge of the market and the history. All I have is a charge from my governor to try to help make it work. And so that's why I'm asking for your help. I'm going to need it. And sometimes we're going to get 95% of the way there on certain issues. Sometimes we're going to get 50% of the way. Sometimes we might be complete opposites. But I can't do it without you. I can't do it without the doctors. I can't do it without the managed care companies. And that's going to be the approach that me and my team always take.
Welcome to South Carolina, Tony, and thank you for being here today. The issue that I know that you've heard before, and I'd like to hear your thoughts about this, and that relates to the issue of hospitals making a voluntary contribution to be able to take advantage of the federal match. And you know this far better than I do. I was talking to one of the SCHA staff that if you're a disabled male and make more than 50% of the poverty level, you're not eligible. Or if you're a mother with 3 children, if you're much above 150% of poverty level, you're not eligible. So these are the poorest of the poor. I mean, these are people who have very complex illnesses. it just seems logical to us that we take advantage of the opportunity to that multiplier effect. And I definitely agree with your comments about using it wisely and coordinating the care. But why wouldn't we want to do that, to be able to make sure that we're not leaving those people underserved?
Well, I think a few things. I think one, it's not an either-or solution this year, and maybe even next year. The combination of strategies of reductions and leveraging and the legislature coming up with additional dollars, they all have to be put in place. And so we're not going to, even if a provider fee, tax, voluntary contribution was put in place, the problem is so big that it doesn't, it wouldn't fully solve the problem. There would still need to be reductions. And I certainly don't think that money, and I guess this is where the governor is coming from, that money wouldn't really be to expand services. It wouldn't be in return for anything new. It would basically preserve the status quo. And I think if we go from the principle that what we need to do is drive cost out of the system, a provider tax doesn't do that. It's the, I guess, it's the easy solution for hospitals, but it's the difficult solution for legislators and the governor, because you're asking them to pass a tax, which we know in this environment is very difficult. And so I think the root cause of it is that, again, I can't just think of my department as an organization unto itself. We have to think of it as part of the bigger budget, and the governor has to look at all those priorities, and the legislature has to look at all those priorities. And by going to a voluntary contribution that simply adds more money into the system, doesn't drive cost out, it doesn't incentivize the legislature to look at other parts of the budget where they should maybe be shifting money back into healthcare, because we know that over the past few years, close to $1 billion was shifted out of the Medicaid program for other priorities. And you know, it begs the question, what were those other priorities, and should they still be priorities in terms of the grand scheme of things? And so I think that she clearly believes that the provider tax is a non-starter, that what we don't want to do now is bring more cost in the system. We need to drive cost out of the system. And so that's both of our rationale. I know that you're going to argue differently, and we understand that. But I would hope that some of the best conversations I've had with many different provider groups start with, here's how we think we can drive costs out of the system for the state. And when you start conversations like that, they seem to go better than when they start, here's what we want the state to do for us immediately. So covered a lot of ground there, and please challenge me on it. I understand that this is the issue to be talked about.
Again, I